So this webinar is being recorded, and a link to the audio and video will be sent to all Maternal Health Supplies Caucus members in a couple days. The recording will be stored in our website, and you're most welcome to write your questions in the chat box while presenters are presenting. We will have space for questions and answers. Without further ado, please let me introduce our moderator today and the chair of the Maternal Health Supplies Caucus, Dr. Metin Gulmesoglu.
Thank you, Milka.
Over.
Good morning, good afternoon, everyone. Thank you for joining this 90-minute webinar on implementation, introduction, studies of postpartum hemorrhage commodities. I think year 2023 is going to be like a year of postpartum hemorrhage. There has been a number of initiatives, large meetings, and the largest of which is the PPH Summit that took place in March. And recently, some of us were in Cape Town at the IMNHC conference, where there was a lot of emphasis on maternal health commodities and especially postpartum hemorrhage commodities. So we have a relatively busy agenda of presentations. The presentations will refer to the implementation studies that different groups conducted and completed, and they have been presented in part or in full in earlier meetings. So we have given them 5 minutes per presentation, and we will be strict about that. And then we will go to 2 opportunities from donors to improve introduction of PPH and underutilized commodities in maternal health. And we will finish by Mariana Widmer from WHO taking us through the PPH Summit that WHO organized and how the conclusions and the roadmap that has been developed relate to postpartum hemorrhage commodities. So within the set of presentations, we put a couple of minutes of discussion time, which we will moderate, and that will depend on our speakers starting and finishing on time. So without further ado, I want to introduce our first presenter, Sarah Rushwan from Concept Foundation. And Sarah will present our multi-country implementation pilots in the next 5 minutes. Thank you, Sarah.
Thank you, Metin. Hello, everyone. And yes, I'll present a quick summary of the ongoing analysis from the multi-country implementation pilots we conducted, which were part of a broader project supported by MSD for Mothers to improve access specifically to heat-stable carbetocin and tranexamic acid in high-burden sub-Saharan African countries. This was through national policy change, clinical protocol development, and then conducting these pilots in a subset of the project countries. So the aims of the pilots were to assess the acceptability of the developed clinical protocols under the project and to generate evidence in order to inform development of an implementation strategy for the introduction of these 2 medicines. The pilots were conducted in the 5 countries that you can see on the screen, so Burkina Faso, Ghana, Ethiopia, Sierra Leone, and Uganda. And the country partners are listed as well. The study timeframe was 5.5 months with 4 months of preparatory work, including obtaining IRB approvals. I will only mention the overall objectives of the study, which were to assess safe and appropriate use of heat-stable carbetocin for PPH prevention and TX safer treatment, and also their integration into routine care. And within this overall objective, we had specific study questions that you can see on the screen relating to comparing active management of third stage of labor before and after the introduction of these medicines in order to assess their feasibility of being introduced into BMONC and CMONC facilities. We used the mixed methods approach for this study, and it was a stepwise approach where we initially collected baseline data for 2 months in all of the selected health facilities in all countries. Then we trained healthcare providers on safe and appropriate use of the 2 medicines, and the medicines were then introduced into the study facilities in all countries, and data was collected over a 2-month period during the implementation phase. I will move on to the results. So I will start with the quantitative part. And just to note that the Ghana results are not included in this combined country totals, as the analysis, we're still pending further analysis of the Ghana data. But overall, for PPH prevention, in the 4 countries, HSC was used safely and appropriately during the implementation phase. So you can see that 79% of patients received HSC for prevention. But you will also see that there are 7 cases where oxytocin was used in combination with HSC for prevention, as well as 4 cases of misoprostol used with HSC for prevention. So those particular cases need further investigation. In terms of uterotonic timing of administration, they were administered within 5 minutes of birth during both baseline and implementation. And the proportion of women who received a uterotonic within 5 minutes of birth went up from 77% during baseline to 91% during implementation. And just to note that there were no adverse events from HSC use reported during the implementation phase. Moving on to PPH treatment. So in the 4 countries, in total, 5.4% of patients received TXA for treatment, and 78% received TXA within 3 hours of birth during the implementation phase. And there were also no adverse events reported from TXA use. So overall, it was used safely and appropriately in accordance with the guidelines. During both phases of the study, we asked healthcare providers to report on how they measure blood loss after delivery. And 75% reported that they visually estimate blood loss. And this was during both baseline and implementation. So I think that really speaks to the ongoing issues with poor objective diagnoses of PPH. And then quickly, just this is just a snapshot of the some of the findings from the qualitative research. So based on combined responses from all of the study countries, we asked healthcare providers to provide us with reasons why they had hesitancies over using these 2 medicines. And during the implementation phase, so post-training, they mentioned that their main cause of hesitancy around the 2 drugs was related to lack of availability. I think for the sake of time, I won't go into too much detail here, but I would say that the main lessons learned from this research is the need for more effective, practical, hands-on training with supported supervision. We also noted a lot of issues with record keeping. So there's a need to improve training on the documentation of uterotonic and TXA time of administration, as well as encouraging healthcare providers to take ownership of training and monitoring use of the 2 medicines. So in summary, the study demonstrated that HSC and TXA can be implemented safely and appropriately in BMONC and CMONC facilities, with the need for refresher training and supportive supervision, as well as dedicated training to improve the issue of documentation. Thank you very much.
Thank you, Sarah. You owe me 1 minute.
Sorry.
So We'll quickly move on to Tunde Amode from Nigeria Smiles for Mothers team, and Tunde will give us the Nigeria pilot for Smiles for Mothers PPH commodities introduction. Tunde, over to you.
Okay, thank you, Mathan. All right,
Do you want me to do you want me to share your presentation, or you'll do it?
I'll do it if you enable me.
You can.
All right.
You can.
Okay, still telling me who's disabled. Okay.
Okay,
All right,
now.
thank you.
Okay.
Yes. Just can you confirm you can see my screen?
We can see your screen. We can see your last slide. That's good.
All right. Thank you very much. Good day, everyone. So I'll be presenting the implementation research by Smiles for Mothers Nigeria. The research was conducted in 3 states of Nigeria, Kano, Lagos, and Niger State, during the period of June to December 2022. The topic was mainly on transferable and replicable learnings on the safe and effective use of alternatives to prevent as well as fix postpartum hemorrhage in Nigeria. This implementation study was part of a whole package interventions in the selected facilities, and part of it was improvement or updates of normative documents, which was the essential medicine list as well as the life-saving skills manuals for Nigeria. The program did provide stock of HSC to ensure that clinicians have the experience of using HSC. There were training and mentoring of healthcare workers around comprehensive emergency and obstetric care. There were periods of supportive supervision to improve facility processes like data collection and reporting, as well as work in the community to improve demand for in-facility deliveries and improve and increase health literacy of women and their spouses in the community. So for brief background, Nigeria accounts for a large number of maternal deaths. Which presently we have a maternal mortality ratio of 1,047 per 100 live births. Majority of this is due to hemorrhage, that accounts for 23% of all deliveries. The present context is that oxytocin and misoprostol are available of poor quality. Oxytocin, we have up to 73% from without conduct nationwide of oxytocin found to be ineffective. And misoprostol, we have about 33.7%. For the availability and provision by WHO that HSC could be used as an alternate, which I told you was a welcome development. And the only issue was that we had little evidence as to acceptability and feasibility of use in the hospital. So that's the content the work for Smiles for Mothers in Nigeria. Overall, aim for the study was to generate context-specific evidence as to how to effectively use alternatives to prevent and manage PPH. The objectives for this study was to describe the current clinical administration practices for the 3 popular alternatives used in the country, which were oxytocin and misoprostol, and of late it's the carbetocin. We were also looking to ascertain how acceptable to physicians HSC was for prophylactic use. And finally, we're also looking at factors that would enable the appropriate use of alternatives in the various health facilities that we had worked in. We had a cancer experimental study, and we selected 18 facilities. The selection was not random, it was more purposefully because there were context-specific issues around the facilities. And so especially in some of the northern states, So we had to be very intentional in the facilities we picked. We had quantitative data collected as well as qualitative. And for the quantitative data, we had looked at charts of 943 women who are delivered in facilities in the implementation period. We also had some structured interview with clinicians, doctors, not individuals. And then we had in-depth and 3 informal interviews with 18 personnel per facilities who were mainly senior officials in those facilities. Overall, we did have a mix of personnel.
Tunde, you have 1 minute to finish. Tunde, you have 1 minute.
So the results, I'll go right to the results. Well, what we found was that each table vaccine was readily used for vaccine as well as cesarean delivery. We had almost 75% delivery in the intervening period being used, being taken or being administered during active management of first stage of labor. We also saw that Lagos State, where we can add earlier experience with HSC, there was overall lesser uptake of HSC. One good thing that we saw was that during the period, HSC wasn't used for induction or augmentation of labor, probably due to the fact that we did have extensive engagement with healthcare workers. So on acceptability, we found that it was high. 13,475 deliveries were conducted using HSC provided during the period. We also did see that clinicians had reasons why they had resorted to using HSC. One major one was ease of administration. They also looked at the safety for use during active management of first stage. And cost was a major factor, which was due to previous experience, because for us, the HSC provider was a public access price. As the same price with oxytocin and misoprostol. Finally, for factors that were responsible for this decision, one major thing was awareness, and which was us letting them know that HSC was available and at what cost. It also involved the training around how to administer it and the availability at point of care. So once it was available, the healthcare physician resort to using it. If it wasn't, they then go for alternative. So awareness, availability, and cost was major issues or major factors for them making their choices. The next thing we did learn was that there is a high acceptability of HSC to be added through the present humanitarian for PPH prevention, and there is opportunity to scale up for use in other facilities and other care work. There is also the need for training and clinical mentorship to enhance knowledge and confidence of healthcare workers to utilize HSC. And issues around supply chain also need to be addressed, and this will be, of course, linked to sustainable financing and improving cold chain facility for oxytocin usage in conjunction with HSC. So for during the period, we did, of course, have limitation. One of what we found was there were issues with documentation, but with supportive supervision to facilities, we did see an uptick that there were improvements, but it could be better. So we hope that with more support, facilities will report more. The availability of electronics also has free stock. Availability of electronics as free stock also could have been a bias to work extensively, but with multiple how much of uptake will occur in facilities. The purposive nature of selection of facilities may also have affected our result. And HSC experience was one major one in Lagos. The HSC had already reduced cases. So this giving us the information that it is for foods have improved utilization, but there will be need for more time for that to occur. So that's the end of it, excuse me. So in conclusion, we believe that for policy makers, health managers and donors, especially working in resource constrained setting, HSC is a good add to electronics for PPH prevention. The fact that there will be no need for cold storage, fixed cost, and now bringing us resources to be applied to other areas. But then it also provides a electronics that we know will be of good quality and probably resolve all the issues around lack of electricity and cold storage facility that's rampant, especially in the rural areas of Nigeria. Thank you for listening. I'll hand over to Martin.
Thank you, Tunde. And you got away with it because I think Daisy hasn't joined, so I let you continue. You owe me 3.5 minutes there. But I appreciate that your connection was not ideal as well, so I didn't want to interrupt too much, and I hope people could generally follow. I saw that there were 1 or 2 notes about not being able to follow comfortably. So let's move on to the UNFPA team. Catherine, will it be you or Tuan presenting?
Hello.
It will be Tuan.
Great. Tuan, you can share your screen. You have 5 minutes.
It is strict.
Yes, it's been disabled. Hi, Milka. Could you allow me to share my screen, please?
Thank you.
Yes, Dr. Tom, just a second. How did you join? And I don't find your name.
Nguyen Tuan Tran, Nguyen.
There you are. Okay. There you are. Ready, Tom. Yeah.
All right, let me try here.
Share screen.
Share screen.
And open the window.
Right.
Open window, there.
All right. Presenting here.
Perfect. Now you want to put in presentation mode.
Hello, everybody. Thank you for organizing this, and I'll be up to the challenge under 5 minutes, which is incredibly difficult. So on behalf of UNFPA and partners from Uganda and South Sudan, working in humanitarian settings, I'd like to encapsulate our finding in this implementation study. We do hexabecabetocin and TXA in both countries. As you know, countries hosting humanitarian settings have a large share of global maternal death, newborn deaths, and stillbirth. And that allows us to think of our overall strategy, where we didn't want to get just hexabecabetocin and TXA into the system without an overall strengthening PPH prevention and treatment approach, like a QI, quality improvement like approach. In this respect, our research objective were to first identify a package of PPH intervention that would then include hexabecabetocin and TXA, and to strengthen basic obstetric services. So we work at the BMONC and not the CMONC level in humanitarian settings. And then to evaluate the package effects on trends in the use of uterotonics for AMSO, and then uterotonics and TXA for PPH treatment, and overall evaluate the feasibility of the approach by understanding operational barriers and enablers. That would allow us at UNFPA to inform our discussion on integrating these 2 life-saving commodities into our interagency or preventive health kits. So it was an overall complex design with several steps, and I'll focus on the testing of the package. And we had 6 sites in each country. So again, humanitarian, and each of the sites went to 4 different phases. You can see here, phase 1, T1 was routine care, upon which there was a refresher training focused on PPH skill drills, and we added TXA and its becapitocin. Then T2 was to see how that refresher training in itself, which is a low to high frequency, only a 2-day face-to-face meeting, preceded by webinars and self-learning before, and skill drills and continuous medical education afterwards. And so in T2 was intervention package alone, and T3 we added carbetocin, and T4 we added TXA. So to take away here is that we didn't add the 2 medications at the same time. So in both countries, you can see how and the number we recruited our participants. And let's get to the carbetocin for AMSL. You can see that actually there was a very good uptake of oxytocin overall in baseline already, and majority of providers do use Eutrotronics. And once we introduce carbetocin after T2, you can see the shift from oxytocin to HSC. And you can see in T4 that there was a stock out, and then oxytocin increased. There were some rare cases of combined oxy and miso, and more concerning for us is carbetocin and oxytocin, knowing that carbetocin has a longer half-life. So the lessons learned from this preliminary finding is that carbetocin can replace oxytocin for PPH in cold change challenge settings, such as humanitarian settings. We can have a potential reduction in oxytocin order and cold chain transport storage by around 90%. It's potentially time-saving, potentially life-saving as well. And what is important is that the qualitative research indicated is operationally feasible and acceptable to providers in the phase introductions. And we need to absolutely reinforce the training and the message not to combine carbetocin with Eutrotronics for preventions. And what is important is also the investment required for staff training, database supervision, and program monitoring, as the other presentations reinforced. Now, side findings here is that our detection ratio of postpartum hemorrhage visually increased after the refresher training. So you can see that. So you can see the pictures of how we did the drill skills and the recognition of stains on different paths. Now, TXA and oxytocin for PPH treatment. This is the interesting part and surprising part. You can see that oxytocin, which is part of the PPH treatment protocol, is universally used in T1 and T2. And upon introduction of carbetocin, they appear to have a confusion state among providers, and it dropped down to a quarter. We had modeling evaluation. We told them this is okay to use oxytocin after you use carbetocin for prevention, and it climbed up to 72%, but not to the universal 100%. So something to bear in mind. And with regard to TXA, once it was introduced after T3, we had almost a universal use among women with PPH. And we already had some uptake beforehand because we delivered both medication after T1. So providers don't wait for the right timing to use it. So we had similar trends in Uganda, but because of timing, I don't want to dwell too much on it. However, the uptake in T4 for TXA was a bit lower due to heavy staff turnover and the time lag between our training and our intervention. So our message here is TXA can be integrated into PPH treatment intervention in BMONG level. We need to reinforce the message as well, the training that TXA does not replace the need for oxytocin. So it's oxytocin and TXA for treatment. So, and we need to also reinforce the message that oxytocin is the main oxytocin for PPH treatment, even after carbetocin is used for PPH prevention. Again, feasibly operational, acceptable, and it requires the same points as before. Am I on time, Committee? And so
Not
the take-home
really,
messages.
but
The take-home messages you can see is right here. You can reread it, and I think that the slide speaks for itself. On the right side, what we need to reinforce in terms of this bundle of care, and that TXA is part of this bundle. It's not oxy or TXA. So, conclusion: our package of PPH intervention mostly refresher training. We had other smaller components, but this package, when it integrates TXA and carbetocin, can significantly increase and change the trends of this medication in our settings, so humanitarian and coaching challenge settings. We require capacity development, continuous supportive supervision, and robust M&E. Note that it was an intervention research, and we use only the maternity logbook. And we believe that with the challenge implementing this in humanitarian setting, it can be easily scaled up in other similar goal change settings as well, coaching challenge settings. Thank you.
thank you, Tuan, and thank you for trying to stick to the time. I know these were for all the groups, they were presented at much greater detail earlier on, so it's a little bit challenging to tighten it. But I think we have a couple of minutes because we saved a little bit of time on one missing presentation. My one or two takeaways is, first of all, how poor the quality of data capture, data collection or recording in peripheral settings is, which I think brings a challenge about appropriate use. The other is, I think, the pre-birth use worry. Probably training addressed it quite satisfactorily, and we didn't see it, and it hasn't been an issue in other pilots. But there has been these few, but still counted cases of HSC together with misoprostol or oxytocin in both our Concept Foundation implementation pilots and the UNFPA pilot as well. So maybe that was a kind of a blind spot that we didn't foresee happening, and we need to perhaps focus on it in trainings. So any questions from the audience to the presenters? Tunde, Sarah, Tuan? Please raise your hand or type it in the chat.
Your microphones are unmuted, so you can unmute yourself and ask the question. It's a shy audience.
Okay.
Okay, sorry, then let me jump in. Sorry, I was also shy for a minute. I just, yes, thanks for the presentations, and it's just reconfirming to see and hear your results, that basically that we can use the new medication also in low resource settings and in humanitarian. You kind of pointed out training as something really important, all of your presentations, and I'm a bit, let me say, like in between, or maybe want to challenge you, because training is always part of medical services. Like if you introduce something new, we need to train. This is not something highly strange. So I wonder, is this like, does this now need a very special training, or we just need to train because this is a new treatment option? I wonder here, because we also, like, part of this whole discussion about using heat stable carbetocin is also the fear that maybe providers are, let me say, not skilled enough or don't really understand not to use it as a treatment as of now. So what is your experience here with the training and fear and the use of heat-stable carbetocin as treatment? And one more for Tuan, maybe also like for humanitarian, I wonder, because you also training in humanitarian settings is a bit of a challenge. And I wonder if yes, how you did this, or how do you see the chances to use apps or recordings or something else to actually overcome the barrier to humanitarian challenges?
Thank you, Luna. Tuan or Catherine, do you want to respond to both the training question and training in humanitarian settings and tools that may be applicable?
I can start, and then maybe Tuan can come in. I think it's a very relevant question. It's true, there's new molecules and things coming into the market all the time. So in our study, I think we started with the baseline that we knew there was a lot going not the best way in PPH, which is why we focused the training on PPH. And I think what we're trying to address with the introduction of new molecules is not a new molecule, but PPH. There's a lot of shortcomings in PPH. And what we did learn, and that's why we're underlining it again, is that the basics and the rapid and systematic approach is not good. Knowledge is good. Practice is not good in the healthcare providers that we encountered in the field. And that even well-known things such as bimanual compression that are known to be life-saving, they are not known. So we think as we go ahead and add another molecule or another 2 molecules to a complicated treatment and prevention algorithm, we do need to accompany this with training, because it is not with introducing the molecules that we're going to make the shift. It is with insisting on adequate PPH management with new molecules that we will make a real shift. So the same is in humanitarian settings, only even more. So I'm less worried about heat-stable carbetocin being used for treatment than I am for being used for induction. So I think we cannot have kids going out there with something that looks like oxytocin, because the little flacon is exactly the same, without being sure that it's not even in the national protocols in some places, without being sure that the implementing partner has given the adequate training to the staff and that the staff can make good use of this product. Ron, do you want to add, or got it covered?
Thank you, Catherine.
I just want to say also that the settings where we work were protracted, humanitarian settings where training was possible. And we should not forget all the opportunity given with preparedness. So there's a lot of training that can be done knowing that the country or setting will move into a crisis. So that you know very well as well, Luna.
Thank you. Mariana?
Yeah, I have a question for Tuan. So thank you very much for your presentation. My question is regarding when you introduce HSC, you saw a decrease in the use of oxytocin for PPH treatment. Do you know why this happened? Is this because they thought they didn't need further uterotonics to treat the PPH, they are misunderstood, or they use HSC also for treatment? So I'm pretty worried about this, actually. Thank you.
Catherine, you want to start?
I can. I think there's different elements, Marianne. So one thing that we realize is that communication about this is very difficult. And I'd like to underline that we had the training, but we also had all the wall charts in every maternity. So they had job aids, they had the little booklets. We insisted on the messaging over and over again. And despite that, one of the hypotheses that we have is we insisted a lot that for when you use heat-stable carbetocin, there's no need for another uterotonic for prevention. And then, you know, to shift to, okay, now prevention is over, now we're talking about treatment, and there you can combine things. You don't have heat-stable carbetocin anymore, you don't use that again, but you can combine, you should actually combine TXA and the other one. That seems to create confusion, which I don't think has to do, you know, probably we could have done the communication better, but it is simply, if you look at it, the treatment and prevention algorithm is complex. When can you combine products? When can you not combine products? Which ones can you repeat? Which ones can you not repeat? When you go through the sequence of having done the prevention and she bleeds, the placenta is not out in 30 minutes. There's so many instances where you reshuffle the cards on uterine tonics that it is not easy. And introducing another one is not easy. So it can be done. The providers were delighted with the effects of heat-stable carbetocin. There's no doubt. I mean, this works. They were very happy with it. But it does need not only training, it does need monitoring. So if the curve went up again, it's also because we picked up on it. And we said, like, okay, WhatsApp group, what's going on, you guys? So it is something that, and I think Metin and Sarah can say that, dig in their data and see if they found something similar in their data, but we found it in both countries.
Yeah.
And indeed it's works.
Maybe
No,
the
I
emotive
agree.
results, Metin, would help. I mean, the use of the bundle and.
Yeah, I think, from a distance, when you write it up, it sounds simple, but implementation, I think, as Catherine mentioned, it kind of changes the paradigm a little bit, and maybe it's not as straightforward as it seems.
We have a question in the chat, Metin.
Yeah, there's a question from Trish Coffey about high cost of HSC and availability of both drugs and country implementation plans. I think the high cost is perhaps negated, that there is a access price for heat-stable carbetocin in 90 countries, and that brings it comparable to oxytocin, quality-assured oxytocin UNFPA catalog price. That's by definition agreed. TXA prices are all over the place, and we are kind of currently collecting data on that, but I think they are not controlled or regulated, strictly speaking. And then I think one lesson that we learned is the pilot countries were happy with the implementation pilots, but then the question was how that pilot will continue into a real implementation. And I think that's a challenge for the whole caucus community about introduction of these commodities. So maybe that's a nice segue to the next two presentations or two opportunities to talk about how we can support introduction plans for these commodities. So Milka, over to you, and then we'll hear from Stephen on the UNFPA initiative.
Okay, so can you see my presentation, Metin?
Yes, you also have
Okay.
5 minutes. Huh?
Yes, sir, will do. So as we have been discussing, scaling up and training are huge challenges that we're facing with the introduction of new molecules. And as Catherine was saying, it's not just about the introduction of new molecules, it's also about the management of PPH. So we are very happy to announce, and we've announced it already through several channels, but Merck for Mothers and the and FCDO, the UK aid, has been supporting the Reproductive Health Supplies Coalition and Clinton Health Access Initiative in creating a new COF, a Catalytic Opportunity Fund, for the introduction and scale up of new and lesser used medicines. This is a pool of funds managed by us and CHAI and funded by MSD and FCDO, and it is intended to increase access to new medicines, heat-stable carbetocin and tranexamic acid, for prevention, heat-stable carbetocin, and for treatment of PPH TXA. The goal is to provide funding for government-endorsed catalytic activities that drive quality, new and lesser used medicines, introduction and scale up in low and lower income countries as defined by the World Bank. So this is a fund that it's already out there. There is no deadline. And so the fund will remain open until we provide all the grants that we have envisioned. The activities that will be funded are activities that increase efficiency and effectiveness of medicine introduction, or activities that are critical to medicine introduction. And also the opportunity should demonstrate how they will lead to tangible time-bound results for scale up, specifically leading to the sustainable increase in availability of quality new and lesser used PPH medicines. COF activities have to be government endorsed, and the government should explicitly state that there is adequate medicine stock and or a procurement plan to ensure adequate stock to support the activities. And the COF activities should demonstrate how they utilized or build sustainable processes, systems, and or resources for scaling up. So we have really two big aims here: training, scaling up, and government endorsement and government leadership with these projects. As I said, the countries that are eligible are low and lower middle income countries as defined by the World Bank. The country has to have these new PPH medicines included in their essential medicines list and or in their clinical guidelines. They have to be registered in countries, and countries should have already made the decision to introduce these medicines into their procurement plans. The two medicines that are eligible for this COF are the heat-stable carbetocin for prevention and TXA for treatment. Activities to scale heat-stable carbetocin alone are eligible, or heat-stable and TXA. Only TXA are not eligible. We want prevention and treatment at the same time. Funding parameters. We have 9 months to implement these projects. The funding ceiling is $100,000 per application, and there are no limits to the number of applications that one applicant could make. And all applications are accepted on a rolling basis. So there is, at this point, there is no deadline. We're accepting applications as they come in. So I think that this COF can help some of these challenges that our presenters have been mentioning during their useful presentations. So thank you.
Milka.
Thank you, Metin.
I have one or two questions, but do we have Stephen or someone from UNFPA to present the other fund?
Unfortunately, Steve hasn't been able to join us, Metin. I've sent him reminders, but he's not in the in the session. We do have Martin Smith from the RHSC, the director of the RHSC, who has joined us recently, and also Debbie Armbruster has joined us recently. So welcome to you two. Thank you.
Hi, Debbie. Is there anyone in the audience who can speak about the UNFPA underutilized commodities fund to give us a little feedback, because we don't get 38 people together every day. So if there's someone who can maybe brief us, and then we can take questions together.
Is Stephen did not join? Because I was counting on him. If not, I would have reached out. Stephen Mauer.
Yes, he hasn't joined. He confirmed his participation, but
Yeah,
he hasn't
I saw
joined.
that. That's why I didn't inquire. I'm not fluent on the subject. I know it exists and we use it for TXA internally, but let me rather try to reach out to him and see where he is.
Okay. Debbie has her hand up in the meantime. Debbie, maybe you can fill us in.
Well, I can only fill in a little bit, but I'll share with you what I know. I know that there are 5 commodities on the list: TXA, heat stable carbetocin, and I apologize, I'm not going to be confident to list the 3 family planning commodities. And countries can choose which commodities they're interested in. And I know that for Madagascar, they chose heat stable carbetocin, TXA, and 2 of the family planning commodities, but not the 3rd one. Exactly how the mechanism works, I'm not sure. I do believe that the country offices dialogue with the ministries of health around interest. And I'm afraid beyond that, Metin,
Thank you.
Yes,
Thank you.
my understanding is that the governments have to approach the UNFPA office in country, and then they will apply for this fund for this underused medicines. And this is the UNFPA fund for underused medicines.
So I'm happy, since you're going to be sending out the recording, I'm happy to follow up with Stephen and make sure that we get something written of that to all of those who are interested as part of the feedback from the meeting. And I'm sorry about that. He's not on his WhatsApp, so it must have been something that wasn't planned.
Okay. Thank you, Catherine.
Thank you.
Milka, one question. This I noticed when we heard about the Catalytic Opportunity Fund in Cape Town as well, that countries can apply for HSC and TXA introduction and HSC introduction alone, but not TXA introduction alone.
Right.
Can you explain the logic behind that or reasoning?
That was one of the requirements from our donors, that we would fund training on heat stable carbetocin and TXA, or heat stable carbetocin alone, because that was a requirement of the donor. It was part of their terms of reference, Metin.
Okay. It is a bit of a pity, because there could be a situation where there is quality assured oxytocin available and no TXA, and that would have made an application useful, in my opinion. Uche has his hand up. Please, Uche.
Thank you very much, and thanks, Mika, for the presentation. I think in introduction, I find that commodity is critical, and it's critical for the first reason, which was pointed out by the presentations by Catherine, Tunde, and Tuan, for clinical experience and training of health workers. So I think for the catalytic opportunity, it's excellent, but if countries have to guarantee supply of commodity, or have in place some order that shows they are going to be able to get a commodity, then that in itself can be a very big rate limiting step to introduction. So my question is there an opportunity where, based on what we heard about UNFPA's funding as well, that can provide commodity, where the catalytic opportunity is then to support countries to access that, and in that way already solve one of the bottlenecks? But if you having commodity available in the first place as a bottleneck, then everything we're talking about around training, implementation, research, of even getting the product in the hands of the health workers to get a sense of it, learn and use it and build that clinical experience, then we'll end up not achieving the scale we want to. So just thought to throw that in as a comment, but also if you have any thoughts, Milka, on the catalytic opportunity and thinking around that. Over.
Yes, and basically the reason why we have designed the fund this way, this small grants fund, is to ensure that governments have a stake in the project, that it's not just someone's or an organization's idea, but that the government is a true partner. The government should assure the provision of the medicines. So one way that we have seen, if the government has not included TXA or heat stable carbetocin within their procurement plan, they can access the UNFPA fund. So the small grants funding is not meant to purchase the product, but it's basically to do training, to do scale up, to do procurement plans, to really help the country ensure that they use this new innovations as soon as possible. But unfortunately, the provision of the product is not included in the terms of the COF. Government, that's why you need the buy-in from the government. You need the partnership of the government. There has to be a leadership role for the government.
Okay, I think it's a bit challenging to put the small NGO in the country to get the government buy-in, where organizations like UNFPA, WHO, and USAID can probably generate that buy-in much more easily. But anyway, let's get to Mariana, and she's going to tell us how WHO is going to change the PPH landscape for the future.
Good afternoon.
Oh, Sanjita?
Yeah. Hello, everyone. Yeah, I have got a few queries. Thank you for all the very nice presentations. And I'm representing, I'm from the government's Nepal. So I have few queries, since PPH is a leading cause of maternal mortality, so is there evidence-based study that introduction of carbetocin will decrease the maternal mortality? That evidence studies will be helpful. And another, it's a cost, which is always a barrier in introduction of any medicine in a government plan. So cost-effective analysis of this carbetocin HSC in the introduction of medicine. And next, from most of the presentation, we have heard that training is required for implementation of this HSC, but training for just for introduction of HSC, it will be a very burdening or limiting for its introduction. So I think a good clinical protocol, a clear cut, which will give a detailed guidance, when to use, how to use, everything. A good clinical protocol will be helpful compared to giving a training or introducing HSC with training. The management of PPH training is okay, but if we introduce for HSC implementation, we need to have a training, then it's become very burdening or a bottleneck for a government, especially in the low income countries, to introduce it. So these are my query. And the most important, that this HSC introduction, is it evidence that it has reduced the maternal mortality? So that evidence will be a very supporting factor for the government to introduce it in their plan. So I have this query. Thank you. A very good presentation.
Thank you, Dr. Shah. Maybe Mariana can also respond to some of your comments, but Jeff Jacobs shared in the chat the price commitment from Ferring and the company in terms of access pricing in low and lower middle income countries. I think in general, and I can probably speak for UNFPA on this as well, that the training has been about postpartum hemorrhage prevention and treatment, not solely on one ampule being administered. So I think it includes the broader approach to best practices and clinical protocols and national guidelines as well. But let me give the floor to Mariana, and Mariana, maybe you can refer to WHO's normative policies as well. That may be helpful for the audience. Thanks.
Okay, thank you, Metin. So I will try to share my screen. Can you see it? Yes, good. So I am Mariana Widmer. I work in the Department of Sexual and Reproductive Health and Research at the World Health Organization in the team of maternal and perinatal health. And today, very briefly, I will discuss with you what we did for the Global PPH Summit, the results, prioritization exercise, and we'll show you very briefly also the roadmap. So the question is, why did we propose to hold a PPH Summit at this point in life? And the answer, unfortunately, is that we still need to join forces, or we need to join forces, actually, to combat this condition. PPH is still the leading cause of maternal death. Only 2 medicines have been innovated in the last 30 years. There are inconsistencies in the international and national guidelines, and there are important implementation barriers beyond adoption of global norms and standards. So due to all these reasons, and in order to be able to catalyze action to reduce the number of women suffering PPH, at the end of last year, WHO set up a steering committee to advise on the methods for identifying and prioritizing gaps in the areas of research, norms and standards, implementation, and advocacy. Therefore, we conducted online and in-person consultations to define the key gaps in research as well as in guidelines, bottlenecks in implementation, and finally, we also looked at the type of advocacy that was needed to reduce the number of deaths related to PPH. And with all this work, and here I'm running because I know because of the time, all this work, we took it to the PPH Summit. So all this work was then discussed in a big community, PPH community, which was constituted by people coming from more than 50 participating countries with diverse backgrounds, and that we met for 4 days to discuss and look at all these gaps that we identified. So this group was able to identify 15 priority research topics in the areas of innovation, implementation, and then cross-cutting between innovation and implementation. Here, I'm showing the 5 top research priorities in each of the areas, and in bold, they are the ones related to commodities and innovations. So under innovation, the top priority was the alternative routes of administration from tranexamic acid. Then we had heat stable carbetocin for PPH treatment, then comparative effectiveness of uterine tamponade suction devices. Then we also had strategies for engaging the private sector in R&D of new products. Under implementation and related to commodities, we had strategies for ensuring access to quality assured PPH medicines. And under cross-cutting, we had tranexamic acid for PPH prevention. We also looked at bottlenecks, and we prioritized categories of bottlenecks for focused global efforts. And here we have the 5 priorities bottlenecks. And you can see that we also have something related to commodities and procurement. We have weak procurement and supply chain systems. So we know that there are PPH commodities that are not available, frequent stockouts, and poor quality of the medicines used to prevent and treat PPH. We also worked on advocacy, because compared to other health areas, PPH ecosystem lacks leadership and funding consolidation. So the group thought that a unified global branding strategy with integrated global, national, and local advocacy frameworks could help drive and maintain attention and funding. So all these gaps that we identified and all the activities related to these gaps were put later on in this roadmap. So we created a roadmap to combat postpartum hemorrhage between now until 2030. In this roadmap, we have several activities related to the different gaps that we identified during the summit. So for example, under addressing priority research gaps, we have one activity that is related to commodities, that it's to clarify and disseminate the innovation pathway that it was presented in the PPH Summit. We also have other activities, of course, related to research gaps. We also have activities related to addressing priority gaps in norms and standards, and we have activities related to addressing implementation bottlenecks. And here again, we have activities related to procurement and supply chain topics, such as we are proposing that WHO and partners will scope solutions for procurement of maternal health commodities. This will happen this year. This year and next year and the following years, WHO will also work jointly with key stakeholders, particularly ministers of health, to set standards for in-country regulators to approve commodities that they have already SRA approval or they are already pre-qualified, and mandate use of quality assured commodities. We are also proposing for the coming years for WHO to work with partners like UNFPA, GFF, to explore leveraging existing procurement initiatives for PPH. So this is the summary of the full roadmap. As you can see, we have different strategic areas: research, norms and standards, implementation, advocacy, and we have all the activities that we are proposing from now until 2030. That is the time that we are proposing to review of pending or new research gaps. All these activities are related to research, new research, update or generation of new recommendations, generation of consolidated recommendations with other international organizations. And regarding commodities, we are proposing to create a new procurement initiative to support countries in procuring quality PPH commodities. This is an activity that we will start working on at the end of 2025, and it will be until 2030, and for which we need to join forces again, and we are welcoming anybody who would like to contribute to creating this initiative. Apart from the roadmap, another result of the PPH Summit was the production of a call to action on 9 categories of stakeholders. So these 9 categories were on industry and innovators, donors, women and women's groups, ministers of health, implementers, professional associations, guideline developers, research community, and international community. So this call to action, we think that it can draw the attention of stakeholders to the critical needs we have identified. So the idea is that it will motivate and guide commitments and increase public accountability to improve the PPH outcomes. So in the area of industry and innovator, we are proposing key messages to focus PPH R&D on fit-for-purpose, demand-driven innovations that will address unmet public health needs via strengthened involvement of healthcare providers, including midwives. We are also proposing making commodities more affordable and accessible, especially for low and middle-income countries, and then also to commit to generating the evidence required to inform health policy development processes at global and country levels. The other area that is included in the call to action that is related to commodities is the Ministries of Health. So, and this is about steering national procurement to quality assured medicines and devices and ensure appropriate staffing and equipment of health facilities. So this is it. As you see, Metin, I have run to save you time. This is the QR that you can, where you can download the roadmap. You have all the information there. And now I'm happy to answer questions and provide more details because I am aware that I really rush to get all this information. Thank you.
Thank you, Mariana. That's great. And this is exactly what I had hoped you would do, because it will give us a little bit of time to have questions and answers. Any questions to Mariana about the summit, about the processes and plans for follow-up? Mariana, maybe I can kick off. The new procurement mechanism that you mentioned that would come in place in 25-26. Is there any reason why it's scheduled for 25-26, or are there sort of preparatory activities that can start now?
Yeah, unfortunately, the main reason is funding. So we have already identified funds for embarking on activities related to guidelines, normative work, and produce updated recommendations by the end of this year. So many of the activities that were shown on the slides are depending on funding. So I think if, as a group, we are able to identify funding and we are able to identify a working group that could invest time this activity, we could reconsider the timing. Yes. And the other thing is working on the innovation, the pathway that it was presented in the summit. This is something that, yes, we have to deliver by the end of this year, and for which I expect the caucus to collaborate, because what we presented in the summit was just a proposal and to initiate discussions. So this is something that we also can work together to improve it and then disseminate it. Mm-hmm.
Okay. Catherine, maybe UNFPA obviously is a natural partner in this context. Do you want to, or Stephen, I think, joined. Maybe we can ask Stephen straight on.
He has just joined. Good morning, Stephen. Welcome.
Hello.
Hi.
Hi. Sorry, I'm joining late. I'm just coming from another meeting. I'm not sure what I'm being put on the spot for.
Doesn't matter. You are on the spot. So, Stephen, we had you as a presenter for the UNFPA's underutilized commodities fund work to give some information to this audience, which is primarily concerned about postpartum hemorrhage commodities. We had all the presentations. We are at the end of our session, but Mariana was just presenting the WHO PPH Summit follow-up activities, where she referred to a new possible procurement mechanism for quality assured maternal health medicines for 2025-2026, which is kind of contingent upon funding. So my question was, UNFPA being one of the major players in this field, how have you thought about a new procurement mechanism? Or perhaps you can say a few words about the underutilized commodities fund as to how people can approach. Debbie Ambraster just gave us a brief summary that there are 5 commodities with heat stable carbetocin, TXA, and 3 family planning commodities in it. But how people can approach, or whether it should be governments approaching the UNFPA for funding.
Okay, thank you. Let me see if I can address all that in the remaining time. The new and lesser used fund at UNFPA is part of the UNFPA Supplies Partnership, which probably many of you are familiar with. It's a fund that has been created to basically facilitate access to either new products, all those products that are there, but they're underutilized in the public sector. And the main objective is to kind of be catalytic to encourage governments to accept these new products without it impacting on the ceiling we usually give countries for support. Now, how it works is it's a relatively flexible funding mechanism. We have a group of reproductive health products, including contraceptives, like DMPA-SC has been there for quite some time. We also have hormonal IUDs that are also in that category. We have medical abortion supplies like combi packs, MVA kits that can also be procured using that funding. And we have the PPH medicines as well. That includes the heat stable carbetocin, the TXA, also in that category. So how this works is, one, a country has to be a member of the UNFPA Supplies Partnership, and there are 54 countries. In case that information is not readily available, I can share that, but it's available on our website. And that's one criteria. The second criteria is it should be part of a national supply plan. So it's not a case where maybe one NGO wants to have the product in the country and then they come to UNFPA. No, it should be part of a national plan. So for that matter, there should be a national introduction plan. Or if it's a product that's already there, maybe they can come up with a scale-up plan on how they want to introduce this product and make it widely available. And then, of course, we look at if maybe there are some trainings that are to be done, if the product is registered in the country, if there are guidelines, standard treatment guidelines, for example, all the protocols have been updated and so on. So if we are satisfied with all those preparatory activities, then we make approval for the quantities that have been agreed as part of the national supply plan, of course, based on availability of resources. And then we do that procurement and consign it to the Ministry of Health in the respective country. The Ministry of Health can work with partners to have this distributed to health facilities, to have it administered and monitored and reported. And based on the consumption, then we can review the forecast, update the supply plan, and of course, look at the subsequent approvals that can be done. Typically, countries are eligible to access this funding for 2 years, but it's an arbitrary timeline because we understand product introduction is not as smooth as it's written in the introduction plans. So we are relatively flexible on that. You may be able to access it maybe for 3 years, depending on the progress that we see on the ground. So in a nutshell, that's what it is. It's not a secret funding basket, but the entry point really is to have a conversation with the UNFPA country office where maybe partners want this product to be introduced. And if they have technical working groups, that's another forum where this can also be discussed. But we'll appreciate the request coming through our country offices. Right. Although we can also be contacted directly, and then we can reach out to our country offices to put the partners in touch with the country offices to have those conversations with the Ministry of Health. I hope that addresses some of the questions that are pending for me.
Thank you, Stephen. Very helpful and clear. So if my understanding is correct, both for UNFPA scheme and the current RHSC scheme, COF, the gatekeeper is the governments, and one has to go work with the all the country partners, NGOs or entities will need to work with the governments in order to access these funds, if I'm correct. Okay. Any other comments? There's something in the chat. Daisy, sorry, we passed your presentation. You were not there, and I think we ran out of time to go over your full presentation, but please, the floor is yours.
Yeah, sure. Very sorry, I was a little bit out of network, so my apologies. Just a clarification from the UNFPA representative. Just wanting to know whether this is a one-time request and consignment by the country team, probably like once a year over the 3 years you spoke about, or can this be done, you know, for example, multiple times within the year? I'm just reflecting on how you purchase the family planning commodities. And sometimes I've seen that it's not just once a year, it's probably more. So would this be the same? Thank you.
Basically, our approach is to integrate the management of these new products into the routine commodities that are already available in the public sector. So we do approvals based on demand. Let's say maybe Nigeria requests for 10,000 units of heat stable carbetoxin in January. This is processed and shipped maybe in May. They distribute this, and maybe around July, based on the consumption, they realize they may need additional support. That can be considered and, of course, approved and also procured and sent to the country. So it's not a one-off procurement. That's why we ask for that introduction plan, because it details where the government wants this to head. And we know it's something that will not be suddenly stopped. So the idea is to use this fund to be catalytic, to get the product in the country, in the supply chain, to support the rollout, and of course also use it to advocate with other procurers to come in and also fund the additional needs that may be generated from these initial introduction activities.
Thank you, Stephen. Kabir, you had a question in the chat, and I think it has been answered. You are good with the response, or do you want to raise it again? It was about price concerns and whether there is a plan for subsidized price. And I think for heat stable carbetoxin, there's already a subsidized price, but not with TXA.
Yeah, I think it's addressed by Milka. So my question was, a long time back, if you may remember that, we had some PGA or volume guarantee kind of mechanism with the manufacturers. So in the long run, if the pricing and the cost is a big concern for many of the ministries of health and government, so I think in future we can, will there be any kind of possibility of exploring that kind of mechanism with the donors and manufacturers? I think Milka has addressed it, that right now there is a subsidized pricing, but what would happen in the kind of big macro pictures in the future when it will be, all the governments would like to implement that, national scale. So then it has to be some kind of agreed principle between the donor and suppliers.
So Currently, this agreement is driven by the tripartite agreement between WHO, Fairing, and Merck for Mothers, and it doesn't have a time limit on it, but it has a number of country limit on it, and it's a public sector access price. So I think there's still scope for doing more for access to heat stable carbetocin as well. Thank you.
And I don't want to speak for Fairing, but my understanding is that they have made all the efforts to lower the production costs so that they will be able to offer a competitive price compared to oxytocin. So I think that's the aim of the company, to provide a product that will be comparable to oxytocin. And they've made a lot of effort in finding alternative fabrication sites and that, so that the product can be made in a more economic way. Yeah.
Thanks, Milka. Great, thank you everyone. And I think with the exception of Daisy's presentation, we went through everything in good time. And thanks for the lively discussion. Milka, thanks for organizing as usual, as always. And I think we have a next webinar in early June, in about 2 weeks' time from PATH. So please keep an eye on that email that will come your way. But for the moment, thanks to presenters and Mariana and for WHO PPH Summit roadmap. And have a nice day, everyone. Thank you.
Thank you, Metin.
Bye.
Thank you, everybody. Thank you, Martin.
Thank
Bye.
you.
Good to see you, Luna.
Milka, should I send the link to somebody asked for the job aids? Maybe
I did. I would love to. I would love to share them with the caucus, with the full caucus. We have about 600 people in our listserv, so we reach a lot of people.
So I've put the way it's organized now. It's on the JPIGO website. So I've just put in the chat. I've put the link, but I can also send it separately.
I don't see it.
Oh, okay. Let me put it again.
Maybe if you have missed the sent.
Oops.
I don't see it in the
Oh, I
chat.
can't send anymore. Why is that? That's odd.
I haven't finished the.
Oh, there you go.
Yeah, there it is. There it is.
Yeah, I think I did it to Metin by accident.
Yeah,
So
that could
this
be.
link you get on the website, and there you can have.
I'll share it with
guides,
the caucus.
The facilitator guides, the job aids, everything is there in different languages and also with different image. You can have the East Africa image, and speak because it's a lot with visual aids, so that moms are looking context specific.
So thank you so much. I'll share it with the caucus.
Okay.
And thank you for coming today.
Thank you very much, Milka. Bye.
Have a great day. Well, have a great evening.
Right. Bye.
Bye-bye.